Good afternoon, everyone. Welcome to the SDGHI Annual Policy Lecture 2025. My name is Arpita Raja, and I'm a Senior Research Assistant with Policy Core at the SingHealth Duke-NUS Global Health Institute, where I support research, policy, and implementation initiatives. I'm delighted to be your host for today. On behalf of SDGHI, I would like to thank you all for joining us today, and a very warm welcome to our guests from Chulalongkorn University, Bangkok, Thailand. I hope you've all enjoyed the refreshments and are ready for the program to begin. Before we begin, I'd like to quickly go over a few housekeeping items. First, please ensure that your phones are in silent mode to avoid any disturbance during the lecture. Second, please take note of safety instructions. In the case of an emergency, stay calm and use nearest exits located to your left or your right, leading to the main entrance, and do not use the lifts. If you need any assistance, please feel free to approach our staff anytime. Lastly, please feel free to ask questions at the end of the lecture. There will be a dedicated question and answer session, so please raise your hands and mics will be passed to you. There are mics on either side of the theater as well. Now, let me briefly introduce the SDGHI Annual Policy Lecture Series and why we're all gathered here today. This series is an annual initiative by Policy Core created to provide a dedicated platform for discussing key health policy issues in Singapore, the region, and beyond. Today, we are proud to be hosting our first annual lecture. This series brings together policymakers, researchers, practitioners, and other stakeholders to share insights, exchange experiences, and foster meaningful dialogue. It encourages collaboration and innovative thinking, helping identify solutions to complex health challenges that cross national and sector boundaries. At its core, the series emphasizes the vital role of policy in shaping the resources, systems, and innovations that determine the health and well-being of communities. We're excited to begin this important conversation with all of you today. Now, without further ado, it's my pleasure to introduce our distinguished speaker for this afternoon. Professor Kenneth Mak is the Director General of Health at Singapore's Ministry of Health. A respected clinician and policymaker, Professor Mak played a key role in Singapore's COVID-19 response and continues to shape national healthcare strategies. Professor Mak also chairs the Communicable Diseases Agency and the Consortium for Clinical Research and Innovation, strengthening the nation's health research and pandemic preparedness. Alongside his leadership roles, he continues to shape the healthcare system by practicing as a senior consultant surgeon, bringing valuable clinical expertise to his work. Please join me in giving a warm welcome to Professor Kenneth Mak.
Well, just orientating myself so I know how to use this device in front of me. I don't have any speech. I haven't actually prepared it. I prepared slides, and I think this is perhaps a bit of a conversation that we'll carry on. When John kindly invited me to give this talk, I was quite happy to do so. No policy talk, so it puts a bit of pressure on me to set the bar. But actually, if you think about it, if I don't establish a very high bar, it's just always good room for further speakers downstream to improve themselves. So that freed me to think I could take a little bit of liberty, being this the first, prepare a few slides that guide me along the way in this conversation I'm going to have with you. And perhaps then we can co-create a learning opportunity for all of us today. This being a talk relating to innovation, I thought I would choose something that may be a little bit provocative, but those of us who are actually in the public health policy space or in the regulatory space will recognize that it's always an inherent tension between regulation and innovation. And often we find it difficult sometimes to determine which leads which and which, in fact, then guides the development of the healthcare system that we have. So I thought I'd spend a bit of time sharing a little bit about my thoughts on this. But I come from the point of view not as a strict healthcare regulator, but come from the perspective of being a healthcare policy maker, being the Director General of Health in Singapore. I should point out, that's the title slide, that I hold different roles within the healthcare system. Those in Singapore know me as the Director General of Health, so in that context, I shape the care model that we have in Singapore. And my colleagues in various other countries would be in the departments of health or in the Ministry of Health doing the same. We have various agendas which relate to the public health challenges we face in our individual countries. And in Singapore, very particularly, we have concerns about the aging demographic that we have, and that's a similar conversation that may be present in some of our countries as well. And we shape our care model, we shape the priorities on the basis of what we recognize to be the challenges we face in our system. But I also hold a health technology agency that's known as ACE, the Agency for Care Effectiveness in Singapore. And in the context of the work that they do, I also have a role because I helped also to participate in the health technology assessments, particularly for national policy in terms of what we would support, subsidize, or introduce into our public healthcare system. In those conversations, we focus not just on clinical efficacy of the various products and therapeutic devices that we look at, but we also look at clinical cost effectiveness, which is not necessarily the dimension that other healthcare regulators might take. So that's an additional dimension that I'm involved with. And the third area which I'm involved with relates to research. And this is a new role, something that John had something to do with, because John was the founding chairman for a consortium, bringing various research enterprises in Singapore together in the biomedical space. And that is what we call CRIS. I've taken over from him earlier this year as the chairman, the second chairman for CRIS. And in that capacity, we look at research, how we want to promote biomedical research in Singapore, but more importantly, how we translate that research into clinical applications that can be mainstream into our care model, our healthcare system in Singapore as well. So irrespective of where I come from, in the different areas that I work in and contribute within the healthcare system, the question that I pose for all of us has relevance because it relates to innovation, it relates to regulation, and relates to that balance that must take place between regulation and innovation. In terms of what I should say, and in a different forum, in a conference on quality improvement and patient safety that happened to take place in Singapore last week, one of the speakers shared this, and it says this was from George Box, and it was actually related to statistical models. He's a mathematician, but he said that this particular saying that he had, in fact, has led itself to many applications elsewhere. The point being made is that there are many mathematical and statistical models that we use, and model to be correct and true. But notwithstanding whether or not there are various inaccuracies associated with the application of a particular statistical model, there sometimes are valuable insights that you can still draw from those models, bearing in mind the limitations and how it's applied within the setting in which it's introduced. So therefore, the saying, all models are wrong, but some may be useful. And inspired, therefore, it says, it doesn't matter where I come from or where we all are, perhaps there will be an element of truth that resonates in each of us as we share our different perspectives coming in. And it might still be useful to gain insights. Unfortunately, after this particular insight that was gained in this particular conference, I happened to be doing my usual literature read, looking at articles from a variety of different places, and I came across an article that came up in an oncology journal. And then it went, all models are wrong, but yours are useless. So, so I hope it doesn't come across that way, that whatever I say is spectacularly useless. And I certainly hope, therefore, that something that can be of benefit to all of you as I share a few insights, particularly from the Singaporean perspective. So with that in mind, let's talk a bit about healthcare regulation. And all of us are involved in some aspect of healthcare regulation. Those of us who are regulators in our own sense sometimes feel that we are defenders of the gate, which allow trade, we allow things to come in, allow external influences to come into our protected kingdom, our system, almost as if there were barbarians at the gate and we have to, in fact, defend against that. That's a very risk-averse perspective. But nonetheless, philosophically and fundamentally, a lot of healthcare regulation relates to this as well, because there's a conscious and palpable sense that we promote the well-being for the population, and we maintain and control that, and we are the bastions for support of safeguarding that. So a lot of how we craft our regulatory systems is aimed to promote, protect patient safety in one shape and form. And a lot of the considerations that we make as we appraise new innovations, new products, new devices, new drugs coming into our system deals with that, whether or not it is clinically efficacious, so ethically it's appropriate to introduce that in our system, because we wouldn't be bringing something in if it causes more harm than good. But yet at the same time, patient safety allows us then to think about what potential harms can be introduced as a result of introducing a new drug, a new device. And this often are the principal considerations that regulators have when they appraise these new technologies. But there are many other opportunities for regulation to influence the care model design, because regulation itself may sometimes suggest the areas for endeavor in terms of prioritizing areas which we think need developing in our healthcare system. And often, healthcare regulation might, in fact, be a spur towards new innovation, new directions, new ways in which we want to introduce services in the country, as opposed to just simply being defenders of patient welfare, safeguarding the rights of a patient. And that's an evolved understanding of what regulators can do. This is, of course, a classic example of why healthcare regulation is so important and why it sets in place that fundamental reason why we talk about patient safety. And we all know about the thalidomide issue, about how it led to fetal anomalies taking place. And as a result, a lot of strengthening of our healthcare regulatory frameworks took place across the world, primarily with this view towards safeguarding patient safety. To some extent, often these incidents occur from time to time. And each time that occurs, it reinforces this prime mission that regulators have. Unfortunately, sometimes it also spurs the pendulum to swing very much to one end. And it leads often to the perception that regulators are very restrictive and very strict and dogmatic about how things should be done. And that frustrates innovators. It frustrates researchers. It frustrates scientists. It frustrates people who are involved in raising startups because of their frustration in navigating the system, hitting wall after wall of bureaucracy, endless lists of rules, and a perception that really regulators are often behind the times. And the systems that we have are not fit for purpose. When we look at regulation, we should acknowledge that regulation takes various shapes and forms. And often the conversation we have of talking about healthcare regulation would depend on which part of the ecosystem that you're in. But if we look at it from the point of view of what we regulate, then there are probably four broad domains that we actually will be looking at. The traditional ones that we are comfortable with, that we are very familiar with, relates to therapeutic drugs and medical devices. And they're the traditional areas where we're most comfortable and familiar with. But regulatory, in fact, has an influence in other areas as well, because we also regulate how services are introduced, services are designed, and we regulate against bad practices that otherwise may occur, poor governance that therefore threaten, again, patient well-being and safety. While we do this, this is often less appreciated that we also regulate physician, healthcare professional behavior, because through our regulations, we impose standards, and these standards dictate what is the training required for professionals to engage in their professional activity, how they should be qualified, and given the license to practice in our respective countries. So if we think about it, regulation covers all four domains. However, when it comes then to its influence on innovation, it may be that in certain of these domains, the clarion call for more innovation is more obvious than in others. But it's important to recognize that innovation takes place even now in all four domains. And I will suggest to you where we see that innovation arising. For drugs, I think that's somewhat obvious and intuitive, that new drugs are always being manufactured and developed as an improvement to existing drugs that provide what is otherwise recognized as standard of care. And often the parameters by which we would then consider to introduce these new drugs would be on the basis of better efficacy compared to the standard drugs, or even if it was not inferior to existing drugs that we have in our armamentarium, they are associated with less harm. And therefore, it is a safer drug to use. And even if it was neither safer or more efficacious, but equivalent, then we look at a cheaper way of doing things. And therefore, drugs are often appraised on the basis of their clinical efficacy, characterized by outcomes, looking at harm versus benefit analysis, looking at harm reduction, and often also looking at the quality of manufacturing to ensure, therefore, that there's consistency in how drugs are produced. Medical devices often follow along a very similar set of considerations. And often, in many jurisdictions, the regulators use very similar approaches to evaluate devices as we do for drugs. There are tensions where sometimes these approaches don't necessarily fit the areas in which these devices are coming in. Devices often are associated with much shorter product development cycles as opposed to drugs. And it would not be surprising that sometimes we see a new version of a stent or an implant occurring almost once a year or even at shorter time intervals, which poses challenges for us in the regulatory space because regulation and the processing and evaluation of new devices takes time. And regulators often feel very stressed by having to keep pace with the rapidity in which new devices come into the market. Also, there are new devices that are coming on board that challenge our way of assessing, evaluating for efficacy and harm. And we have to think about how we want to adapt our regulatory frameworks to take this into account. When it comes to services, this is less intuitive, but regulation shapes how services are delivered. For example, we have emerging new care models, particularly in response to what we went through during the COVID pandemic, where patients were not keen to coming into our hospitals and clinics to see doctors. And therefore, new models of care anchored around telehealth have started to proliferate, and new care models bringing care outside institutions into the community have started to proliferate in many of our countries. And these may require new ways for which we regulate and how we appraise harm. And we need to think about new ways in which we design our infrastructure and to accommodate these new models. For healthcare professionals, there's a somewhat traditional way in which we assess the fitness of any particular individual to practice his craft within that healthcare professional space. But increasingly, we are finding pressures existing within our respective countries, where our manpower is lean. The demands on that manpower are ever increasing, fueled either as a result of an increasing burden, often driven by the aging demographic, and an increasing utilization of healthcare services. And then with more to be done by a few people in the workforce, there's a need therefore for us to think about physician extenders, people working in the apex of their license, extended practice settings, and new ways in which we want to regulate how we assess fitness for practice in the population. So many things we need to do, and all of it done by regulators across different domains and different spaces. But our understanding of who fits this regulatory label also continues to evolve and change. I mentioned my role in the different ways in which I am involved with, but in the classic sense of being a regulator, that's not quite where I am. Sitting in an office within a regulatory agency, appraising many of these applications that come. But at the higher level, those of us who are in policy space, relating to policy design and crafting, surely shape the circumstances in which regulation would work in that facilitates the introduction of new technologies, new innovations occurring across the different domains I've just articulated. So those of us in that high policy setting, whether in government, in health ministries, would have a significant role to play. Then we have those in the regulatory bodies themselves that are involved with the act of actually regulating, using legislation that government ministries and policymakers may craft, and putting together that framework then allows us to do that appraisal. They work very closely in some jurisdictions with what, particularly in Europe, they call notified bodies, because not all regulatory bodies take on the function of testing and certifying based on standards that have been established. And in some of our other countries, there are distinct and separate entities that just deal with the certifying and the standard setting, while the regulators then tick the boxes and assess whether overall the conditions set or the criteria set for licensing have been met. So in some of our countries, these roles conflate together in various entities, but in others, these functions are a lot more mature, well-designed, and taken on by different entities within our healthcare system. In some countries, particularly in the US, there may be similar functions, but taken on by multiple different bodies, whether at the state or federal level, or sometimes that line in the sand is actually quite blurred. But perhaps in relation to setting, the same innovation might clear multiple different agencies depending on the setting for regulatory and licensing approval. And that complicates our understanding of how regulatory frameworks work as a result of this level of complexity. I talked a bit about healthcare technology agencies, and where they exist, they fulfill a very important role to help us to better understand what cost effectiveness is. And cost effectiveness is often not part of the principal considerations that we have when we regulate innovation, because cost effectiveness is often an ex post assessment rather than an ex ante assessment on the basis of costs that arise in real time, direct and indirect, that shape the care model in terms of how it's done. And it's always appraised on the basis of outcomes that initially might be theoretical and projected, but then validated through real-time experience after the introduction of an innovation or technology or a service. And therefore, healthcare entities that fill the regulatory space may not necessarily do full health technology assessments, but they may only at best do a more truncated assessment that looks mainly at clinical effectiveness and efficacy, the degree of harm that can be assessed, the quality of manufacturing for standards, but not deal with the cost effectiveness consideration. And that particular aspect may be taken on by distinct HTA agencies in our different countries. And there are very mature health technology assessment frameworks, even in our part of the world, in Thailand, in Singapore, and of course in other countries as well. What we appraise and what we adopt as principal considerations would vary. I talked a bit about the need to protect harm and safety. But depending on your perspective and what your framework is, you may in fact have secondary objectives. And your consideration for introducing new technologies would sometimes give credence to these other considerations as well, whether it's in terms of sustainability and paying attention to the degree of impact your technology has in the environment. And this is increasingly becoming more and more important, although it's not the center stage for most of our technology assessments today. Whether it's in terms of data privacy and the degree in which your innovation protects against cybersecurity threats. This may not necessarily be an important consideration when introducing a new drug, but it's certainly a consideration when we now introduce new medical devices, particularly those that are that have either software incorporated in which can be engineered and influenced, and where malware can be introduced, or more recently, new innovations where software itself is regarded as a medical device. So software as a medical device, or SAMD, becomes a new domain that we also have to think about whether or not that needs licensing, with a view towards safeguarding standards for protection of data and cybersecurity. We also look sometimes at regulation with a view towards cost effectiveness, and I mentioned earlier about the role of health technology agencies. They play a role in helping us to ensure that the new innovations, technologies which are introduced also do not inflate the cost of care significantly, and therefore affordability remains a cornerstone for much of our healthcare systems across different countries. This is particularly important when it comes to the low, medium, high income countries, where it is increasingly harder to manage a budget with a finite amount of money for ever expanding healthcare demands. From the innovator's perspective and those who hold IP rights, the next consideration is very important, that regulatory frameworks may sometimes also have elements that are intended to safeguard intellectual property and patents, patent protection being put in. Because by recognizing a device and granting a license, you do provide some level of protection for that device. And it may be a recognition, therefore, that that particular device has IP with a particular company, or particularly in relation to value-based pricing negotiations, locking in the ability for that product to get access into the markets in that particular jurisdiction, with a moratorium sometimes applied against other products coming in order to give that first mover advantage, in order to secure that better price during for value-based pricing negotiations. So indirectly, regulation can protect IP, protect patents, but with a view often of having a higher objective. That objective could be to assure some level of affordability in the system as well. And regulating competition and how resources are utilized sometimes is part of this consideration for regulation. So many considerations, the prime motivation still remains protecting safety and welfare, but there are often secondary considerations. And all these come to bear when we think about its influence on innovation. So there's always this perennial question, which drives which? The chicken or the egg? Innovation driving regulation or regulation driving innovation? And I would submit humbly, it's probably a bit of both, all right, and not necessarily one answer or the other on its own. Certainly, we see examples in more recent memory that all of us are familiar with of how innovation sometimes will drive regulation. But innovation drives regulation, innovation coming in earlier doesn't often occur out of a vacuum as well, because innovation often is driven by a use case, a pain point, a pressing need, a context that drives, therefore, this need for that innovation to take place, or new technologies to be designed, developed, and then manufactured and delivered into the markets. A living example was COVID, a new pandemic, a novel disease, a pathogen that we now had new diagnostic tools to use. Again, an example of innovation taking place. In contrast to SARS, when we had to experience SARS, and for the majority of the time period we were battling SARS, we had no diagnostic test. And therefore, it was often on the basis of a case description, epidemiological information that allow us to think on the lens of probability a patient had SARS. Now we had diagnostic tools. But with a diagnostic tool and ability to diagnose COVID comes then the need for therapeutics and other innovations. And of course, more recently, talking about vaccinations as well. And they were all part of this context that drove a lot of innovation taking place over the last 3 years. But that innovation drove the need also for change in our regulatory frameworks because of the pressing and compelling need for bringing vaccines that were safe and effective into commercial application to vaccinate the masses, to protect them against a new pathogen that could potentially be life-threatening. There was a need for us to then expedite our review processes to bring these vaccines into play. It wasn't necessarily a situation where we took shortcuts, because at various times, we strove to still keep the rigor of our evaluation and our regulation. But it meant perhaps new ways of doing things, not depending on mature, completed, finalized portfolios to be submitted to the regulatory authorities before a regulatory assessment could take place, but to allow a conversation to take place with pharmaceutical companies, to allow for portfolios to be developed in tandem with the research that was taking place. And as you submit the bare bones of initial portfolio, you then periodically refresh that portfolio and render it more complete. And where the information available in the portfolios are sufficient to allow for initial parts of the evaluation to take place, then that could take place earlier as well. And therefore, shorten the overall duration by which evaluation takes place in order then to be able to bring vaccines from bench into bedside. Shades of this conversation has taken place across different countries, different jurisdictions, but these were elements of regulatory change that took place without compromising the principal considerations we talked about earlier, but driven by a context. And the context was an urgency of a situation that often occurs. So yes, innovation can drive regulation, but often in the setting of a context. And of course, there are other innovations that are rapidly coming in. This is an example in the cellular space. We're talking about CAR-T therapies. We're talking about innovations that involve tissue engineering, and they particularly have application in either rare diseases that have a genetic etiology and pathogenesis, but our normal and conventional way in which we regulate them is increasingly coming under threat, because the way in which we bioengineer these products may not lend themselves so easily to using our traditional conventional ways of assessment and regulation. CAR-T therapy, as an example, is cellular therapy. It involves the bioengineering and manufacture of cellular lines along batch processing principles. But they challenge our notion of having a standard manufacturing pro forma quality that is standardized across different batches, because by virtue of the fact you're producing cells, intrinsically there are intercellular differences that may take place between batches as well. So our standards may have to change. Our understanding of what constitutes the minimum thresholds for assessing a product to be fit for purpose then actually changes as well. The assessment of various products and devices falls along the similar lines. Increasingly, we're finding that there are more bioengineered materials being used for these devices, nanomaterials being used for these procedures. Our traditional way of appraising for harm also needs to change, because the nanomaterials do not necessarily stay within the device. The risk of leaching, of simulating into the tissues, both where these devices are placed and even more distant, become serious considerations as well. And what is the impact of harm in that setting? It's a very different assessment compared to the traditional assessment of harm for other medical devices and products as well. When we look at artificial intelligence and data and digital health, we face challenges as well, because often when we do product assessments for regulation, we like to have a product reach a certain level of maturity for assessment, and then after that, consider further re-evaluations when these products change substantially, either in terms of function or in terms of the specifications and characteristics of that particular device. But software is a very difficult situation, and all of us who use computers will know that when we upgrade the operating system, we end up with a version 1.2, 0.5, 0.6. But then at certain times, we have a complete version upgrade that goes from versions 2 to versions 3. And what constitutes then incremental versus transformative, more disruptive transformation becomes a part of that development cycle for services and products like software. And therefore, how do we appraise and how do we regulate that? At what point in time do we now insist that reviews and repeat evaluations need to take place? There's no common understanding of how that will be. So our traditional way, our frameworks for assessing new products is constantly being challenged by these innovations, whether it's in the tissue cellular engineering space, whether it's in gene therapies, whether it's in devices, whether it's involving the materials that are used in these devices, or even these new digital related applications, which relate to software in a medical device or software as a medical device. And therefore, these are challenges that regulation struggles to try and keep up with, and often regulation lags very significantly. It is not a fault necessarily of the system, but it's just by virtue of the pace of innovation that's taken place that poses significant challenges to our regulators. But it's never ending source of discontent among those in the innovation space, because they regard this latency and lag in regulatory change as stifling the pace of innovation. So if I look at and crystal ball gaze a little bit where some of these challenges will be, it will be in many of the areas I've just shared and more. And I've given an example in this particular slide of some of the areas where, while innovation may lead regulation, these are also the areas where regulation will find it very difficult to keep pace. And we have to think about new ways of doing things, particularly in these areas. Whether it's in relation to, as I mentioned earlier, what we call in Singapore CTGTP, so cellular, tissue engineered, and gene therapy products. In other jurisdictions, they use the term advanced therapeutic medicinal products. These are areas which we struggle because of the pace of innovation and the need then to redefine in different ways what harm means and what efficacy means. We're increasingly moving into precision health. And as we move into precision health, new ways of assessing for predisposition for conditions and treatments that result thereafter also challenge our way of regulating. How do you regulate then a treatment for a disease that has yet not manifested, but may be evident on the basis of a risk profile? Becomes issues that we will have to take on board when it comes to further regulatory transformation. When we look then at digital health and software as a medical device, we face considerable challenges. And there are different technological innovations that have taken place in this sphere. We have the machine learning and deep learning approaches, which now might even be regarded as traditional legacy approaches. But they are nonetheless still important because they often drive a lot of what we're doing now in the risk prediction, risk stratification space. Risk calculators are often driven by these machine learning, deep learning applications. And therefore, how we regulate these also may be different from how we regulate other forms of software. In this regard, it is important, therefore, that we ensure that when risk calculators are used, they are applicable and validated for the populations in which we are applying it for, as opposed to validating them in a foreign population where the risks intrinsically for that population may be very different from what it is based on the demographics in Asia or in Singapore. And therefore, we need to take that into account as we regulate these, and there will be increasing challenges as more AI, more machine learning and deep learning applications come on scene. Extended reality applications is a broad generic term that includes augmented reality, virtual reality, and this blend of mixed reality applications that come on board. And we see some of this already in our healthcare system, often as pilots. Surgeons are using it to navigate, to plan surgery before they actually bring a patient into the operating theater, right? And it's used in neurosurgery, in orthopedic surgery, for the spine. My colleagues in liver surgery use this to navigate where the transaction plane should be when they remove part of the liver. So many of these applications coming on, not just in clinical work, but also in the teaching and training space as well. But then how do we appraise this? Because technically, if it's an application that impacts on direct care, it is often regulatory authorities stating that they need to now influence how these applications are used. And then what form of regulation should take place for what is otherwise a virtual reality application is still not quite clear, but it's certainly something that is increasingly being debated. AI algorithms, particularly generative AI, large language models, is something that also is challenging us because of the concern about the risk of harm associated with hallucinations and false conclusions being made, and therefore the risk, therefore, that information being provided to clinicians who use these technologies to augment and supplement their care might in fact lead to wrong or bad decisions being made in the clinical space. And therefore, how do we then appraise this, particularly when many of these AI models is opaque in how these conclusions are made. But increasingly, we're seeing the adoption of what we call agentic applications. Agents are these little bots and processors to deliver a certain AI function. But when you stack these together, you may actually create a pathway which doesn't require a man in the loop. Then comes what is our risk appetite for removing men from the clinical decision space in areas which do potentially have safety and harm concerns. And that's something that the healthcare regulators are starting to grapple with, but we do not have a converged understanding of how we should do this. We're looking at each other to get the ideas, and I think this will remain an area where innovation will far outpace what we're doing in the regulatory space. The telehealth applications are something we're more comfortable with now. We see that in primary care, we see it in hospital care, and we see it in shared care models between hospitals and in primary care. And some of these are used to supplement new care models that bring patients out of hospitals into out-of-hospital settings. The hospital at home sort of care models are starting to proliferate. But the technology is geographic blind. And there's no reason why we would not expect a telehealth service to start to proliferate, where a doctor or care provider is in one country, the patient is in the second country, and the service is based out of a cloud or cluster or platform that's based in the third country. And therefore, it poses challenges for any country or regulatory authority to decide whether or not these are in fact situations that can be enforced and regulated on, because the service doesn't fall so neatly in any of our jurisdictions that any of our laws might theoretically have full governance over. And therefore, we're finding it increasingly challenging to manage this particular space. And of course, I mentioned about extended practice models in relation to professionals and how perhaps there's a push in many of our countries to explore independent practitioner models beyond just physician extension and extended practice settings. And we have then to decide how to change our regulatory stance to accommodate this. A couple of years ago, the GMC, the medical authority in the UK, decided to expand beyond just regulating doctors, and they now regulate physician assistants as well. It's a new category of doctors that are in fact not doctors, right? But they're actually trained to a lower standard, but based on a defined set of competencies and scope of practices. The country has decided that they have appetite to allow these practitioners to work in the healthcare system, but driven, of course, on the basis of expanding healthcare demand and an inadequately sized workforce to be able to provide those health services. But then comes challenges on how to regulate them in terms of training, qualification, and how they should be pitched against traditional doctors. And where an adverse event occurs, what rules to use for the purposes of assessing whether these practitioners have practiced beyond the bounds of their license and then now caused harm. So even though the GMC has introduced this new category a couple of years ago, they continue to sense make almost on a regular basis, shifting their stance in response to the cases and events that occur within their own country. So transformation efforts are not static. They respond to the challenges we're in, but even in an area like professional regulation, there are these emerging challenges, not just in the device, the service, the drug space. It's tempting to say that regulation is a big problem. And since regulation cannot keep up, maybe we should not have regulation at all. And therefore, in some settings, this question has come up. Maybe we should deregulate. Deregulate doesn't necessarily mean no regulation, but it means we should regulate less. Perhaps certain categories of services, drugs, and devices may have been appraised with a higher risk profile before, and therefore require a more stringent evaluation process. But now we better understand the use of these devices. Perhaps we don't have to have that same degree of risk aversity, and we can rule and regulate with a lighter touch. And therefore, we decategorize, we lower the tier in which we regulate them, and where a large evidence-based portfolio needed to be submitted, maybe what we could do now is just regulate on the basis of similarity to a previous product being present in the healthcare system. And in the US, clear examples of that exist. The 501k regulatory pathway is introduced precisely because there are new innovations in devices. They may have piggybacked on previous other devices available. And as long as the technology could be demonstrated to have been adapted and developed of a previous technology that has already undergone a more rigorous evaluation, then perhaps on the basis of a risk assessment that suggests lower risk, we could let that go and therefore not need to impose the same regulatory standards. That has allowed many devices to get onto the market. Whether that stance is appropriate or not, may vary. But we have seen new innovations occurring with a regularity and frequency that outpaces the situation in other markets. Contrast that to the EU, which has a much more traditional, much more risk-averse setting, where often many medical devices still require a full portfolio of evidence, including randomized control trials, where these might have an easier regulatory journey in countries like the US. It is not surprising, therefore, in certain categories, to see half as many devices being introduced into the market in Europe as opposed to in the US. And we were having a conversation with some of you just now, and some in the startup space were saying that, in fact, their preferred journey would have been to go to the US in order to be able to get registration earlier, and therefore allow for their products then to be sold and distributed across many different other countries, US being a benchmark regulator, as opposed to going the European route. So deregulation may sometimes be helpful, but deregulation or no regulation sometimes creates chaos because it introduces regulatory ambiguity, and that ambiguity may cause sometimes more harm than good. In some areas, the absence of a clear set of rules and guidelines leads to paralysis of effort because people don't want to try for fear that they don't know how to navigate the space. or it may mean that you stifle the innovation that otherwise could be possible in the country that you're in, and where others would prefer to spend their time, effort developing their product for other countries and other jurisdictions. And there's a certain economic impact to your country when your research and innovation efforts are all hijacked, going a different route. So no regulation, deregulation doesn't help necessarily. So what helps if it's not going this space? And perhaps the way to go is to think about how we want to make a regulation more adaptive, more flexible, more able to meet the changing situation as it manifests. Whether it meets the aspirational goals of being able to be so timely with little latency that we can literally always be at the crest of that wave that comes is sometimes difficult to achieve. But if we are willing then to learn, be adaptable, and shift as we identify the changes that are taking place in the scene, then perhaps this adaptability creates a greater degree of flexibility that allows our regulatory frameworks to be more nimble and more relevant for the evolving situation we find ourselves in. This level of adaptability can take various shapes and forms. But I think minimally in this slide would be perhaps some of the considerations I think any regulatory framework should have. So first of all, there must be ability for us to have intelligence, to be able to do horizon scanning, to better understand where trends are going, so that we will always be able to predict and tell where the innovation directions are taking us. That may allow us then to anticipate what is needed and preempt some of these challenges before or as they come through changes that we take that we design into our regulatory framework. So having that ability to do horizon scanning is important. And this horizon scanning must assume that the innovations and new developments do not always only come from the domestic space. You now need also to bear in mind that much of technological innovations come from without our countries. So that horizon scanning must be both global as it is local. It is not always easy to sense make where people are moving, because it depends on you either having market intelligence, reading the literature, reading the newspapers to understand what is being published happening in other countries. But it's worthwhile to think about cultivating engagements for industry and stakeholders. The stakeholders allow you to better understand needs, and needs often, as we described earlier, provide the context that drives the innovation. And understanding the needs helps you also to anticipate where innovation will go. But cultivating industry for engagements helps you to provide that insight that helps you to better understand what are the innovations that are going to come over the next 1 to 3 years versus innovations that are a little bit more nascent, which may be paced out but may require your attention over a longer time horizon. It doesn't mean necessarily that engagement introduces a conflict of interest or bias. You can design those engagements in a more neutral fashion that ring fences and separates out and reduces that risk of conflicts of interest. But you cannot separate yourself and blinker yourself from not knowing where innovation is heading. And therefore, I would commend to all of us the need for us then to maintain that intelligence and that sense making of where innovation is driving us. Regulatory sandboxes are much more recent innovation driven by developments in the fintech industry. Even then, in that setting, it's been more than a decade now since the first regulatory sandboxes took place in that industry. But we're a little bit newer to the game. Regulatory sandbox allows for pilots and innovations to be safely introduced into our system through safe spaces that we create. And these safe spaces may be defined in terms of a setting in which the innovations are provided, in terms of duration through determining how long these sandboxes and pilots exist. But often they allow us to test ideas, test the way things should be done in order to prepare for that future reality when these innovations are mainstream. So these sandboxes may test how innovations should be introduced into services, but they may also test how regulation should change to allow for a more robust, flexible framework that incorporates and better governs these innovations. It may even allow us then to test ideas that we have for financial support, financial subsidies, all in the safe space that then informs what we should do when the time comes that we think we're ready for the innovation, whether in service, products, to be delivered as reality in our healthcare system. So sandboxes are increasingly being used. We created a sandbox a few years ago looking at telehealth services, because we didn't know whether telehealth services would be easily managed, governed with the healthcare regulations we had at that point in time. And indeed, when we first did that with people who are prepared to co-own and co-create a journey with us, telehealth companies themselves, it became a learning opportunity for both sides. And we did design the future healthcare framework that we had in Singapore under our now Healthcare Services Act to incorporate this flexibility to adopt these telehealth approaches. So that's an example of a sandbox that we adopted in Singapore. But it may also be a look at whether or not alternative evaluation methodologies need to take place. From the traditional way in which we require a mature portfolio to be submitted, to perhaps indicating an interest in regulating a particular space, allow in an iterative manner for stakeholder engagement, for portfolios to develop as they emerge through research, and for evaluation to keep pace with that based on these developing portfolios. So you start off with a skeleton. As flesh is added onto the skeleton, you appraise accordingly in stages in bounds. This incorporates a more life cycle approach as opposed to the traditional way in which we do things. The assessment doesn't stop at the end in which we give an in-principle approval for a service, a technology, a drug to be actually mainstream, because the life cycle may involve then further assessments post-introduction of that particular technology into our community for further assessment to take place ex post after the initial regulatory approval has taken place. So a life cycle approach sometimes helps us to evaluate that risk-benefit when the risk-benefit profile is not so clear at the beginning, and we run the risk of stifling innovation if we expect all information to be available to us at one point in time for us to do the evaluation. And it may allow us to be a little bit more nimble and to have an earlier adoption of these technologies. But there are opportunities for us to reduce the turnaround time in any of our jurisdictions as well. And increasingly, we're seeing AI applications used to populate portfolios, used to evaluate portfolios, and also then to ease the regulatory administrative burden that we have. And therefore, these are things that are part of the process that we are evaluating how we reshape the regulatory space. And finally, I think it's important that increasingly we think about the patient. We do profess that we have a patient-centered way in which we evaluate services and products. After all, we say that the principal consideration is patient safety and to safeguard their welfare. But patient-focused development takes things a higher pitch. It talks about looking at patient-centered goals and patient-centered outcomes when we measure benefit and risk. And then we bring that patient voice in as part of the evaluation assessment process as well. And these are increasingly developments that are taking place within the regulatory framework. So these are things that are happening, but by virtue of the fact that innovations are introduced across jurisdictions, we talked about the telehealth space already. In fact, what we may need also is to talk about innovations that occur without our countries, between our countries, and adopting common standards across our countries establishes that common language so that when we now regulate, we regulate with the understanding that when we assess a product, a device, a service to be fit for its roles, there's a confidence that this will be the similar assessment in other jurisdictions as well. It gives us a confidence that we can take a product that's already cleared the regulatory authority in a particular country that we trust, and then expedite its introduction into our own country as well. And therefore, these common standards and frameworks become important. There are examples of countries coming together to work in this particular space. An example is the Access Consortium, and we are part of it, together with our regulatory partners in other countries like Canada, US, UK, Switzerland, Australia. So sometimes these serve as ways in which we share information, understanding that sometimes the portfolios that are submitted to us in our individual regulatory authorities are commercially sensitive and therefore confidential, but we may be able to share decisions we made after an evaluation has taken place that helps to ease our own individual countries' subsequent efforts to evaluate the same technology. It also means that we can share best practices and hope, therefore, that each of us then benefits collectively as a system. Globally, the WHO has actually recognized several regulatory authorities as global benchmarks, and it's useful for alliances to build with these global benchmarks, or to think about impressing a higher mission for these global benchmark authorities to then socialize and share those standards with their sister regulatory authorities in other countries as well, with a view towards establishing these common standards. So examples of how we further push the envelope come in the area of what we call regulatory science. Regulation is not static. We've mentioned already about the need for regulation to morph and change on the basis of innovation taking place. But it's a science in itself. There has to be a certain rigor sometimes in how we look at how to introduce these changes that take place and how we regulate. There are examples of how this is taking place. In the UK, they formed centers of excellence. I think there are at least 7 of them. Some of them are duplicates, so the bullet points don't really count to total up to 7. But the bullet points depict the themes in which some of these centers have been formed around. And you realize they're shaped around different kinds of challenges that we see introducing now and into the future, and how regulation should morph to be better relevant for those roles are the center of focus of these research efforts, and in itself becomes a new domain of science called regulation science. We have our own local equivalent. Our Health Sciences Authority has partnered with A-STAR, that research consortium that we have, to look at some areas associated with next generation therapeutics, and to give us new insights on how we should better shape our regulatory framework as well. So these are areas which we continue to push on. We have got a national precision health research-based funded activity called PRECISE, and they, through the introduction of these use cases, are also helping us to better appreciate how regulation should change to govern the introduction of new precision health services. Regulation also in turn can drive innovation. All I've talked about earlier is just one half of this set of conversations. But regulation has uniquely the ability to define standards for safety, efficacy, and these are important that innovators then can take guidance from, because they provide a greater assurance that whatever directions their innovation and research efforts play, it will never undermine and compromise the attention towards patient considerations. But in some areas, it may be the regulation sets priorities for where innovation will then take place. COVID again as an example, we identified vaccines as an important element that we need to develop as a priority, and therefore indicating that we will expedite and bring forward regulation of these products, thus incentivize more activity to take place to develop these innovations, coupled of course with more funding made available in governments for research to be done there. Effectively, these two provide the driver for certain forms of innovation taking place in certain biomedical sectors. And of course, it allows us then also to ensure that there will be innovations continuing to be developed for areas which otherwise will be outcompeted by other agendas. It is often the case where treatments for more common prevalent conditions would take priority over conditions which are rare. But if regulatory allows for certain expedited pathways or dedicated pathways to ensure that they're not out-prioritized, out-competed, then there might still be a space for us to ensure that accessibility to care, particularly for those with rare diseases, continues to be protected in all our healthcare systems. So it's like a dance, right? And in that dance, you may have one partner leading at certain times, and another partner taking his or her turn to lead at other times. And this little syncopated journey, all right, weaving through the entire dance, aptly describes the relationship between innovation and regulation, where at certain times, innovation will drive regulation, at other times, it's regulation that guides how innovation will take place. And this perhaps might be the best way of answering the question, which leads which? Unfortunately, there are disruptions on the horizon, some of which are with us today. We all know this. It is not just simply a basis of a concern for the application of tariffs, which is now the most common conversation we have. But in that particular country, we've seen the activities of the healthcare regulator also being influenced. And to some extent, for some of us, we think that this may not necessarily be a positive development. What that then poses as implications over the next 3, 5, 7 years for the regulation and introduction of new innovations is still up in the air. We'll watch this space very closely, and it has an impact on the rest of us, because in countries like the US, These serve also as benchmark regulatory authorities. Many of the products that are approved by the FDA see themselves subsequently being introduced in our own countries as well. But if these products are not going to be approved through various rules that are put in place in those countries, it does stifle innovation in certain directions, and it materially affects us because then we don't have these products and services and devices to use in our own countries as well. Now, that may not necessarily be a negative thing. It provides then the opportunities for other regulatory authorities to step up, to fill the space which otherwise might have been historically occupied by one particular regulator. But it requires us to have the gumption, the courage to step in and take on these higher roles where otherwise these roles are changing as a result of these geopolitical developments. So I've answered this question, a reciprocal relationship. And based on what I've talked about, there are implications and calls for us to play our roles in different perspectives wherever we are. If you are a policymaker and a regulator, the call then is for you in the midst of these changing times to continue to be bold and adaptive, to continue to keep an eye on how innovation is going, and to think about regulating not just for today, but for tomorrow, taking into account the direction in which innovation is taking place, as long as it remains relevant and fit for the setting in which we work in our respective countries. If you are an innovator, I ask that you continue to put trust in the system, that notwithstanding the challenges that may take place in the geopolitical setting, that you will continue to innovate and trust that we will step up and we will continue to morph our regulatory framework to keep pace with you. And if you are a clinician, I ask that you continue to keep a sense of what is going. It is the clinicians that provide the context that drives the innovation, and you need to continue to fulfill that responsibility of sounding out where the pain points are in the treatments and the services you provide in your particular care setting. And of course, if you're a citizen, and all of us are citizens in our own countries, there's a call for us to all remain engaged, to demand of our authorities, our governments, our regulators, that we will always have them fulfill that social obligation to us for safe, effective treatment, that it retains accessibility to care. So the world is a little bit murky now. We have light that helps to shed our way. It doesn't point out clearly where all the time we need to go, and sometimes we need to walk and navigate step by step through the challenges we face. If you're a pessimist, it may look like this, right? There's a train potentially coming to you, right, through the tunnel. But if you're an optimist, the promise of matching regulation and innovation well leads to you to a setting like this. So thank you very much.
Thank you, Prof. Mak, for the very engaging and insightful lecture. Your perspectives will certainly give us all much to think about in terms of health, regulation, and innovation. Thank you so much. Now, I'm sure all of you have many questions and are eager to hear more. Joining us as moderator for today's session is Professor John Lim, Executive Director of the Center of Regulatory Excellence at Duke-NUS and Policy Co-Lead at SDGHI. Professor Lim is a leading figure in regulatory science and global health policy with deep expertise in health systems governance. He also holds academic appointments at Duke-NUS and the NUS Sauce Hawk School of Public Health and serves as Senior Advisor at the Ministry of Health, Singapore. His leadership extends to the Consortium of Clinical Research and Innovation in several boards, including the Singapore Medical Council. Please give a warm welcome to Professor John Lim.
Well, thank you, Arpita, and thank you very much, Kenneth. That was a really inspiring lecture. You've set the bar so high. I think when we find the next lecturer, that person will be very hard-pressed to match what you've done. I would describe your lecture as elegant, eloquent, enriching, and extensive, and you've covered a whole range of issues, which I think have given us a lot of food for thought. We have about half an hour for questions from the audience, but before we get there, because this is organized under the policy core of Zing Health, Duke-NUS Global Health Institute, one of the reasons for this lecture series is to also try and encourage healthcare professionals within our system here, within our academic medical center, to consider that if they want to engage with policy, and they come potentially from not just a clinician background, but also nurses, healthcare professionals, and a research background, what would be the best way to engage? And we thought that as Director General of Health, we should pose this question to you this afternoon. And there is a diagram that we would like to just show on the screen, which we've thought through in terms of a kind of circle where we are looking firstly at aligning how would one align a research and policy agenda, and then the approach in terms of researchers, how would they look at the translation of this as they work with policymakers and ministries of health into strategy. And then, of course, it goes into the rest of the cycle of assessing impact outputs and refining and adjusting outputs if necessary. But really, my question, Kenneth, is more on the first two arrows. From your perspective, what advice would you be able to give, I think, not just to the audience gathered here, and we have friends from Thailand as well, but also perhaps others within the system? What is the best way for them to engage with policymakers in, let's say, the Ministry of Health Singapore? Because it's not always that simple to sort of follow through, but we are looking for more people to become not just regulators, but also policymakers. So perhaps if you could answer that question first, and then we will come back to the topic of your lecture today.
Okay. Okay, well, I don't think there's a necessarily one-size-fits-all approach to this. You know my background, and I think a little bit was shared with the audience just now. I started out as a clinician. So for those of you who don't know, I'm actually a surgeon. I work in hepatobiliary pancreatic surgery. For a while, I was doing transplants as well, and before I came to the ministry, I was also doing some trauma work as well. So it's a very broad area, but it's all very niche areas, right? In surgery, my role into the policy space really started by taking on administrative responsibilities, and as one recognizes people who do have administrative capabilities, you tend to be loaded with other things. It's all under the name of talent development and leadership development, but one after the other, you start moving down a certain journey. And I moved then into what was basically a clinician and administrator role, a journey, taking on senior leadership roles in my department, then subsequently in my hospital, and then subsequently then transiting on to doing work for the ministry on a project basis. And that more or less moved me down the path of then spending some time in the ministry in the various roles I played. So in fact, at the end of this year, I would have spent 10 years in the Ministry of Health as well. But I still continue to retain a clinical practice. So in a sense, I still continue to have one foot in either door. That's one journey, one particular journey. Then I've got colleagues of mine who have a very clear intent of moving into public health, into health administration at a very early age. Right after medical school, they in fact had gone into residency and specialist training in this regard, and then spent a much longer runway in the healthcare system, dealing with policy design, policy crafting longer than I have, and continue to contribute very well in the system. So I think there's no one-size-fits-all approach. But if you believe very strongly that you may have a potential role to play, a role that's far more than what you are doing currently, particularly for me as a clinician in the area, I think what is important is a mindset that you want to be open to other things beyond your narrow niche area where you work. I could easily just think the only thing important to me is the gallbladder, the bile duct, and the liver, right? And my whole world is just dominated by three structures in the abdomen. But if you're hungry to know a little bit more, keen and curious, then it behoves on you to find out a little bit more what our system is like, what are challenges our population face, and what is being done for it, particularly in our system. Then as you do that, you suddenly develop a little bit of an interest and hunger in asking, what can I do in my little space to contribute to help? That may start off with just a local set of work and contributions where you are, but it may therefore lead to you now starting to develop relationships, attending meetings, settings like this, and being emboldened to ask the questions which have always troubled you. And by asking, you learn, and you make yourself known, and you indicate that, in fact, you're interested in taking this further. And I think it's important that there has been this self-driven set of motivation to want to do more. What we need to do in our end then is to design the processes that allow these individuals who are interested to step up. Some, as I said, come through mature pipelines or through the public health training route. But these other individuals will come in, they will tend get an MPH, and they will find themselves dealing with things that are more than what they had trained for in medical school, whether locally or in the global health setting. And I think we need to nurture and encourage more people to do this. And then they can play active roles wherever it is, whether in regulation, in policy making, or in the interspace, helping to communicate these ideas, shape the way these policies are crafted.
Thank you very much. I think it also echoes some of the stuff you were talking about in your lecture about where the boundaries are breaking down specifically in the context of regulation and innovation. And I suppose even in this area of trying to get more people into policy, we have to think a bit out of the box as well and move out of our traditional sort of silos, as it were. But I'd better come back now to the topic that you've spoken at length on this afternoon. And for this, please, I would encourage you, if you have any questions, to move to the microphone, to identify yourself and to pose the question to Professor Kenneth Mak. But while you're doing that, perhaps I could ask you a question also coming back to what you were saying, and a bit linked to what you've just been talking about, encouraging policymakers. As we think of regulation and innovation, what role would you see a Ministry of Health or a Department of Health playing in this? Because you very eloquently described all the various aspects that go into this, this issue of regulation and innovation. But can we also have setups, platforms where in fact health ministries could facilitate this, or through regulatory agencies? Do you see that as a way to go, like having certain offices in place to facilitate this? Or do you think it should be a lot more organic in terms of how we can encourage this?
I see a diversity of different approaches when I look at different countries and different health systems. And again, they may not necessarily be a one-size-fits-all solution. In Singapore, there's a closer interface between the ministry in setting policy and the regulators, because often some of these regulatory functions are very close to us. It's a stat board. We have some direct influence. Some of our people in the ministry are heavily involved in healthcare regulation as well. So clearly, in a system like in Singapore, there's a very deep intermeshing of two. This is not necessarily the case in some of our other countries, where the regulatory authorities are maintained as a separate and distinct framework. Even in continents like Europe, which is in fact different countries and coming together, there's the European Medicines Authority. They have a regulatory framework that spans across the entire EU, but not necessarily having the countries themselves, it's individual members of EU playing a big role in that regulatory process. But there's a commitment that the governments will support this activity. And where governments then come in, if this regulatory framework is separated out from the ministry, is in terms of supporting funding that allows for adoption, implementation, and sometimes even improving accessibility through subsidies and subventions that are provided to providers on the ground and as well as patients. So there are different approaches that take place. I don't necessarily think there's a one-size-fits-all model. But I think it behoves those of us in the policy space to be very close to what's happening and be attuned, and actually, just as I expect regulatory authorities to do their horizon scanning, it is important that we do the same, because how do you shape policy without understanding what services are being made available and how that goes? How do you shape policy if you don't have an understanding of how the cost of care is going to be impacted by these technologies being introduced into your country? And we see very disturbingly new biologics, new diagnostic products, new tests, new treatments, increasing being introduced for the same condition, but with increased costs over time. And that is a big concern. Often drugs, whether for spinal muscular atrophy or otherwise, it's a few $1 million, coming in per regime. And that surely would strain any particular healthcare system where there is a national system that actually takes on the burden of subsidizing or providing care for its citizens. So I don't think governments can divorce themselves from the entire regulatory framework. And in some of our jurisdictions, it's a much more intimate interface between the two. But it requires us to think of our own local solutions for governments then to keep an eye on this space and subtly shape how regulation should shift, transform to meet these innovation demands.
Thank you. Questions, please, from the audience? You don't often get the chance to interact with Professor Kenneth Mak on an issue like this.
Yeah, because I don't usually talk about regulation.
Yeah. But you've done it very well, I must say. Renzo, but please identify yourself because this is being recorded for Zoom, so it's good for people to know who you are. Yeah.
Hello, good afternoon. Renzo Ginto from SDGHI. As you remember, we were having a chat during the coffee break. I will ask the question if no one is standing up. So, but seriously, and especially because we're in a global health institute, I am interested in hearing from you, Professor Mak. So far as you interact with regulators, health regulators from other, let's say, neighboring countries in Southeast Asia, the developing quote unquote countries of Southeast Asia, what are you what are your observations in terms of the regulatory capacity and readiness, especially with the fast pace of innovation that we are facing? And I'm also thinking, are we ready or should we be considering creating supranational regulatory structures? For example, an ASEAN health regulatory agency. Is it just a dream, or is it something that we can actually make happen, or should we make it happen? Thank you.
Thank you very much for that question. We'll talk about Asia, or more particularly Southeast Asia, because I think that's the context in which all of us are in today. Um, there are different levels of maturity for our systems in our different countries. I think we are quite aware of that. I dare say that there are two countries where our healthcare regulatory agencies, authorities, and frameworks are a little bit more mature than some of the others in ASEAN. That's one, Thailand. And in fact, historically, Thailand has had a framework for health technology assessments that actually was developed much earlier than what we did in Singapore. So from that point of view, I think there's in fact a lot of best practices we can learn from our colleagues in Thailand, and there have been these learning opportunities as well, both in the academic and the practical setting. There are other countries perhaps in that slightly lower tier who do have regulatory frameworks, but they are quite comfortable with what they're regulating today. But I suspect actually as we introduce new innovations, it may take a while before they are able to shift and morph their systems to be more relevant to that. That may include our immediate neighbors, Malaysia, who do have a relatively mature regulatory framework as well. But there are other systems around that, in fact, are less mature in terms of their own organic assets, partly also because they may not have sufficient expertise developed in-house locally to take on this work. I mean, health technology assessment is an example of this. But some of these countries piggyback on the work and efforts of others. So, for example, in Brunei, in fact, they keep a very close eye on what we are doing in Singapore, and they've, in fact, collaborated with us, and we've shared some of the work we're doing with them as well. And I think they do benefit. I see Indonesia being such a big country and developing its own mature system. They have a strong aspiration to want to do this, to develop a much more mature regulatory authority within the system. And I wish them well. I think they have started on a reasonably good footing, but they need quite a bit of help still. And it's then incumbent for many of our other sister ASEAN countries to step in and support. But we have to do this sensitively, because this impinges then on sovereignty and sometimes pride. And we have to do it in such a way that no one feels as if they are asking for scraps of help, in a soup kitchen somewhere. But in fact, we come as equals, hoping to share and then and think about how we want to do things that way. We can establish best practices and serve as benchmark agencies. And some of us actually have achieved such standards as well. But with that should not come the pride of having some internal achievement, but it comes with a social obligation for us to do more for our region. And I think Singapore particularly faces this challenge of exploring how to step up and be a responsible citizen in ASEAN. Yet to do this in a very sensitive way that does not demean, does not humiliate, and respects each other country based on where they are in ASEAN. There have been talk, and my colleagues, I think, in the global health space are aware of potentially forming networks, and some discussions have taken place and to set in some of these parameters, what domains we'll look at, and so on. But there are some practical challenges if we want to think about a larger free trade area, common regulatory framework that spans across all the countries, akin to what's happening in Europe. Some of this relates to our local setting, but some of this actually also relates to what industry is doing also that creates that differential treatment for different countries as well. So let's take drugs, for example. the cost of drugs in Singapore is the most expensive among all of ASEAN. There's this differential pricing policy that takes place. It's much cheaper for the same drug in Thailand, in Indonesia, in Indochina than it is in Singapore. And it's pragmatically on the basis of what the pharmaceutical industry thinks is the willingness to pay threshold that Singaporeans have. But of course, that puts us at a disadvantage. And also means that our ASEAN neighbors are happy to collaborate with us in assessing standards assessments, but they don't want to be tarred with us when it comes to procuring medications. Because if I procure on behalf of the rest of ASEAN, you'll come at a higher price point that may be intolerable to my neighbors. And I have to be sensitive to appreciate this. So, and then if we do it the other way around, right, get it at the cheapest rate that any of our countries have, the pharmaceutical companies may not play this game. Because as you expand your hinterland for which it comes, then obviously it may mean that the pharmaceutical industry will now price the drug at a higher rate than otherwise it would have been if these countries were procuring the drugs directly on their own. So these practical challenges that also mean that while it may be an aspiration that we have much more cohesion, much more unity in establishing this single framework, but pragmatically, we may go some way, but we may not materialize a common market because of these differential treatment, differential practices are taking place across our countries. So I think we are developing some of these networks and collaborations, but I am a little bit cautious to say that we will consummate this relationship with moving completely towards a complete integration.
Well, thank you for that answer. I think just as a point of clarification, as Bob comes to the microphone, I think Renzo's question focused specifically on regulation of health products. But you also alluded to health services regulation. Yes. And I wonder, before we take the question from Bob, whether you could say a few words about Singapore's approach to trying to converge services and products regulation.
Yeah, so we have gone a certain part of the journey, and I mentioned some of this. Some of these are lessons that perhaps our neighbors can look at, but they will have to decide the applicability of these, the way in which we develop services for their own countries and their own jurisdictions, because often services do not just proliferate in a top-down manner. It also relates to the capability and competency of stakeholders in the community for those services actually to be developed. And it's not much point talking about developing PBTs in your country, licensing for it, if you don't actually have the infrastructure that supports this in your country as well. So I think it's important for us to share, but leave the individual countries to decide on the basis of their own context what they will take on board and what they will apply and what they will then move in. But what is important is that the learning opportunities must always be shared.
Thank you. Bob?
So Bob Kamei, one of the founding deans at Duke-NUS. And
you want to speak into the mic because it's a bit soft.
Is that better? Should I step down here? Is that better?
Maybe just speak a bit louder and we'll catch.
Okay. So Bob Kamei, one of the founding deans at Duke-NUS, and over the last 5 years, I've moved into the startup medical device space. So I'm going to ask a question from not the academic side, but from the industry side. I was really, I thought the talk was incredibly thoughtful. It fit in with some of the things that I see the industry needs. The story and especially the adaptive regulatory piece, because startups are usually in very new technology, new advances, where, as you said, the regulatory piece has not had the opportunity to stay up. The story I'll give you is one of the technologies that we were bringing out, not with HSA, not in Singapore, another place, where we embarked in some expensive animal studies for a new product that we had. We were in a pre-submission review, so we engaged with the regulatory agency, started doing the animal studies, and only to find out later, after the studies were done, that, oh, we should have biopsied the liver, the kidney, and then as the regulatory pieces were advancing their own thinking, we come back later on and then are told, no, the things that have been done no longer are sufficient. Okay, so I understand that there's a change in thinking from the regulatory standpoint, and I like the idea of this dance where the industry stays involved with the regulators and that as thinking comes along with the regulators, then it passes down to the industry so we could start to react. I wouldn't say that's exactly what happened, but as we think about this idea of this dance, which is a great metaphor, as we think about this dance, how do we engage with the regulators, for instance, here at HSA? Because from the industry standpoint, I would say that we do the pre-submission consultation, we go back, gather the data, we submit it, and then we get a series of questions back and forth from the regulators, and maybe a year later we get approval if we're lucky. So how do we engage in this sort of regulatory dance that you're suggesting? Because I think that is a really good solution to some of the things that we're trying to do.
Thanks for the question, Bob. First of all, this notion of a dance, I think, is a very important one. But often there are these stereotypes that sometimes trap us into a certain way of thinking and certain defensiveness. So I would not be surprised whether it's on the innovation side or it's on the regulatory side. Some people regard this dance as dancing with the devil, right? And therefore, better not to engage so much because of the risks associated with entangling too much. And often there's this institutional concern about the more I disclose, the more disadvantage I'll be because regulation has been neutral. But you cannot really sense where things will go. And you run this big risk that this institutional inertia leads to so much bureaucratic baggage that really it stifles innovation in whatever shape and form it takes place. So I'm actually a fan that more engagement is important than less. But the setting is different across different countries. But I think this is a clarion call that all of us as regulators in our respective countries should think about a different way of doing things. The level of engagement can take place at different levels. It doesn't necessarily have to be at the final mile when it comes to the regulator that is in charge of processing these applications for registration. Because if you've got an integrated system, that level of engagement can take place in the research space at the beginning. As we better understand what's happening in the research setting, we understand then the trends because we do horizon scanning, and we understand then maybe this work is nascent, but it's likely to see an application materialize over the next 5 years. That gives us the runway to think about how we want to move our regulatory framework across. So our regulatory authorities need to have that maturity, that insight of wanting to do this level of engagement, and not all our countries at that level, I'll be honest, and you have seen those frustrations yourself in the startup space. But we need that healthy behavior then to allow for these conversations to take place. Establish platforms, regulators coming into conferences where innovation is discussed, keeping an eye on what's happening, talking to people, not worried about just simply conflicts of interest. We're just doing this with a view towards better understanding where the direction is, where that vector is leading us to, and better understanding what, therefore, will reach the regulatory horizon over the next few years for us to better sense make what to do next. And I don't think there's any shame for us doing this, but that requires that level of conversation to take place. The conversation is iterative. It starts off very tentative, but as we better understand the technology, it leads us then to be able to ask the questions that are necessary for us to be able to shape the regulatory response downstream. It does require also some level of sophistication among innovators, because there's always this concern about intellectual property, right? Whatever you share with us might be shared with other competing innovators and scientists elsewhere, and we lose that competitive edge because what we think we're doing is years ahead, but then we rapidly lose it if regulators are not sharing this with others as well. So it's important, therefore, that confidentially it takes place one-to-one, or we have common brokered contracts that allow us then to decide what is safe to share and what, therefore, should be kept still proprietary and confidential in order not to betray the trust, which is important for us to develop this sense-making that's going on. So these are my personal views, and I think we need to do this, and certainly within the HSA in Singapore, within the larger regulatory and scientific research community, I think we're developing this more sophisticated understanding of where we should go and the level of collaboration and engagements we should do in Singapore. But we are still somewhere at the start of this journey. I think aspirationally, this is where we want to go. And therefore, even the researcher in Singapore, the innovator in Singapore, the person who has a startup company in Singapore will still experience pain. But this is where I think we should go, and this is what I share with my colleagues overseas as well.
Thank you. Do we have another question?
Thank you very much. Can you hear me? Okay.
Yep, but we have to speak a bit louder so the others can hear you.
Okay. Hi, I'm Ashley from the Center for Outbreak Preparedness. Thanks very much for your talk. I was wondering if you could comment a bit about how regulators and some of us who are not regulators, but let's say friends of regulators, can build public trust in regulatory agencies. For example, with the speed with which the COVID vaccines were developed, it was amazing to some of us, but for other segments of the public, it was a cause of anxiety or mistrust.
Yeah, there's quite a bit of that also associated with new technologies. I think we know that, particularly with vaccines, right? It's all come to the fore, of course, in a certain country across the Atlantic where misinformation, mistruths, and the fear of new technologies is starting to influence what regulation does, what is actually being developed, and what rules constrain the development of these innovations. I need to be careful, just make sure that I still have a passport. I can go travel to those countries. But I mean, it's quite obvious. You know what I refer to. But I'm not sure and not entirely convinced that this is the space that the regulatory authority, in whatever shape and form it is in our countries, has complete ownership on, and it is for the regulatory authorities to actually manage this space. We certainly need to make our processes a lot more transparent so that there's a lot more public confidence that how we regulate, we license, and we register, grant approval for new services, products, drugs, therapies is done in a way that continues to safeguard patient safety. So at the end of the day, it's a trust that needs to be maintained with the public. And therefore, it does mean that sometimes we need to open up our processes to the degree that it allows the public to develop this confidence, so that when we start now approving new vaccine, there's less questions asked about whether or not our process of evaluating is flawed, which is the criticism now being levied against very mature regulatory agencies in countries like the US, right? And that undermines completely the trust and the credibility that the public has for our entire regulatory framework that we have. And this, I see being duplicated, this conversation occurring in many different countries as this contagion effect spreads beyond one particular country into other continents as well. But it's important that that level of trust needs to engage. And that's perhaps the greatest responsibility and obligation that regulatory authorities have. But the need then to combat misinformation, mistruths, malicious attempts to subvert sort of the science into directions that meet perhaps the agenda of a small group of people, that agenda creep and agenda hijack cannot be only for the regulatory authority to do. And this has to be something that all of us have to bring into play: academic institutions, the scientific community, governments of the day, and health ministries are particularly important agents for making sure that we coordinate our efforts to battle this misinformation. So coupled with increased transparency, we hope therefore to continue to maintain the trust and the credit factor that the public has in our respective countries for our regulatory authorities. If not, it will completely undermine our systems of how we manage this. It completely undermine the messaging that we are continuing to uphold public safety and welfare, and it will bode ill for us in how we introduce and manage new technologies in the future. So I think the question you asked is important, but it's not just the regulatory authorities' obligation responsibility. It's for all of us to manage in our different areas. But the first thing we need to do as regulatory authorities is increase the amount of transparency that we have in our systems to continue to maintain that public trust in our system.
Thank you. Do we have one more question? I think this has to be the last question in view of time, but please.
Good afternoon, Prof. Kenneth and Prof. John. I'm Staff Nurse Raj from the National Heart Center. So regulatory efforts seem to me more of as a top-down approach. So I'm wondering, how can I, as a nurse on the ground, without any expertise in the policy-making space, influence the policies that determine the care that I deliver to my patients? And do I have to be high up in the hierarchy to have any influence in this area? Yeah, thank you.
It's a good question. It relates to this issue of empowerment and how we empower people on the ground to make change. I would suggest to first of all that actually innovation doesn't have to be some big thing that's there, that manifests as a result of a big dream we had. A mystical hand writing in the wall and pointing the direction to this big change that will take place, for which we'll win a Nobel Prize for. Innovation occurs on the ground as well. And in fact, if our system embraces and recognizes it, it should empower clinicians of all backgrounds, nurses, allied health professionals, to think about how they want to improve the way they're doing things. And that can actually lead to some local innovation that takes place there. So I think for a start, we need to create that culture and spirit that doesn't therefore assume that, in fact, individuals working in the different areas we are in are not having opportunities to innovate wherever we are. It's just perhaps the magnitude of how you innovate and setting expectations in terms of what you can do for change to occur. It's driven out of the same sense that you want to do something better for your patients. And we need to recognize that. Therefore, our system must be able to recognize these activities as well. It doesn't necessarily mean that it takes the same form of assessment, approval to get it into the system as we would for a drug. But it may mean being willing now to test your ideas, showcase your ideas within your hospital, within your clinic, make suggestions on how this could improve care where you are, and that could then drive its adoption wherever you are. And then as you demonstrate that this is working, it gains traction, that it then spreads across different clinics, different wards, different services, different hospitals. It becomes a mainstream practice. When we started with the hospital at home activity in Singapore, and this is common in many places, we started as a pilot. We started in one particular hospital, and the other hospitals looked at it and said, it's a very good idea. It helps us to alleviate our bed occupancy constraints within our busy hospitals. But more importantly, it shifts care back into the community where our patients want to be. And it provides now for a much more fulfilling care experience for our patients as well, without compromise necessarily on the outcomes. And different hospitals started taking on board. It's now a national mainstream exercise. But it started with one hospital willing to do a pilot. In fact, I can even point to one particular clinician who championed this, because when she was a chief resident, I was having dinner with her and she was trying to interest me in this idea. But I didn't react to it at that point in time. And when she completed residency as an associate consultant in our system, she pushed for the idea and the hospital listened. So people on the ground can make a change, but you need to start up doing it. Don't think that everything you do has to be this high floating thing. Change can occur on the ground. Our system has to respond and embrace these ideas for improvement.
And thank you for the question, because, yeah, please, we can take one more. But I think one of the aims of the policy core of SDGHI is to try and create more opportunities for healthcare professionals across our AMC to engage with policymakers and perhaps to even consider how to become policymakers. So watch this space, and my colleague, Professor Koo Kian, will tell you more in time to come. All right, this must, I think, really be the last question, please. Thank you.
Thank you, Prof. Kenneth. So I'm Tanu. I'm from EID Research Fellow. My question is actually not really a question, but a comment, or whatever everybody has asked and what you've presented. So do you think prioritizing, so for this regulatory section, industry, research, would it be good to prioritize, like for Singapore has a different needs, Indonesia has a different need of healthcare, and Malaysia has different. So they prioritize, like ministries of health prioritize that these are areas that we are looking for to go further. And so that the research and industry is putting effort there. I mean, I'm not saying that other research is not important, but that might fasten or give a direction to the upcoming healthcare solutions.
Yeah, I did allude to it in one of the slides I showed as well, that actually regulation can influence innovation and shape where innovation is developed on the basis of perhaps our prioritization, what's important to our populations as well. Different countries will do it differently. In Singapore, we influence that conversation in part also because of where we provide competitive grant funding. As you know, we've got a national research pot of funding that actually is open for biomedical research, and we have several domains that have been identified as strategic areas for development. And indirectly, of course, you send a message to researchers by virtue of the fact that you organize your funding tranches based on these domains. These are the areas of concern, importance to Singapore. And therefore, you drive more research activity in these areas. And as these mature, they may develop, that lead to spin-offs and innovations that then influence the care model that we have in these same areas as well. Different countries will use slightly different approaches. They may issue on a regular basis a list of areas that they like to see more development innovations occurring, not necessarily always with funding associated with it. But so I think the countries have to create and design their own individual approaches based on the context they're in. But this practice of trying to highlight what we regard to be our national agenda is not an uncommon thing. In fact, many countries are doing this. I'm sure in Thailand, they you do it. Malaysia, I know, does it. We do it as well. Often we use funding as a lever to drive this behavior, but it's not just funding. Sometimes it's just prioritization for registration, for example, accelerated approval in areas of concern. And that's an approach also that the US has done as well. The US also has embarked on very different other alternative ways of trying to drive innovation in specific areas. So for example, APA, the framework, grand challenges is a way of trying to spur activity in certain areas which we regard as important. And that may then lead off to the spin-offs that then hit the jackpot in terms of creating the applications that are useful to us as well. So the answer is yes, we do. We may adopt slightly different approaches across our countries, but it's not uncommon that we do this. There are different levers we use to try and drive that activity, whether it's funding or it's greater access to our system, facilitate approaches towards registration. But whatever the lever, the common approach is trying to encourage innovation aligned to our national strategies and priorities.
Well, thank you very much, Kenneth. I've told this story before, but I said when I used to be at HSA, my chairman and I wrote a piece at that time, which was many years ago. And he wrote, this is Professor Edson Liu, who said that people thought that regulation was as exciting as watching grass grow. But clearly, the way you've described it today simply emphasizes to us that this is really no longer the case. And I think with all the challenges for healthcare and in biomedical innovation, clearly regulation is a very fast, dynamic area. So I'd like to thank you very much for putting things in such clear perspective. So do please join me in thanking Professor Kenneth Mak for this excellent inaugural lecture. Thank you.
Thank you. Thank you.
Thank you, Prof. Mak and Prof. Lim, for the wonderful discussion. And thank you to everyone for engaging and being very active in the discussion as well. This concludes today's lecture. We hope you found it informative and inspiring. Please feel free to connect with our speaker and with us if you have any questions. We also encourage you to stay tuned for our upcoming events in our Policy Core annual series and other events as well. Lastly, we would also appreciate feedback on today's event. So please scan the QR code on the slide and give us feedback on how you felt the session went. Thank you for joining and have a wonderful evening.